Thank you, Ivo, for this kind introduction. And I have the pleasant task to keep you awake or help you through your post-lunch dip. And it will be something different in comparison to what we've heard this morning. It's more on the clinical application of dosimetry and dosimetry in radionuclide therapy. And there is quite a debate on how to apply dosimetry to realize patient-specific treatments. What is quite common in radiotherapy is not in radionuclide therapy. So treatment planning is hardly performed, or it is performed. The usual way of giving therapies with radionuclides is treat all patients equal. And usually it's 7.4 gigabecquerel relating to the old-fashioned 200 millicurie. But there are also actions to go to the maximum tolerability of patients. And I will explain this abbreviation AHASA later. And the last option in giving a more patient-specific therapy is to treat to the right tumor dose. So a tumor dose that will lead to better survival and diminishing of tumors. But we are not there yet. So what do we need to have a better idea on personalization of radionuclide therapy? So first of all, we need to know what absorbed doses are being given. And as said, that the common standard is to give just a fixed activity with hardly any dosimetry. We're lacking quite some data there. And also what's also lacking is the knowledge on the exact dose-effect relation we are to encounter with radionuclide therapies. And the third hurdle to take is there's hardly any standardization in the dosimetry and dose effect reporting. And that's perhaps also an important task for the EURADOS to help to bring out a more standardized way of reporting and doing dosimetry. All in all, we need clinical trials to establish dosimetry-guided therapy. And I will start also perhaps a discussion on do we really need the classical phase 1 to phase 3 trials, or can we rely on a dose-effect relation to really go to a higher dose to these patients and by that have a better outcome? So first of all, in Rotterdam we worked on lutetium dotaocttate, and I must say that we came with this dosing schedule of treating patients with 4 cycles of 7.4 gigabecquerel, and in a phase 3 trial initiated by Novartis, you can see that the progression-free survival in these patients is much better than the control group, and control group got the same sort of peptide but without lutetium. And to give you more background information, octtate is a somatostatin targeted peptide to treat neuroendocrine tumors. So you see the success of this 4 times 7.4 gigabecquerel. So progression-free survival, the median survival is not even reached. And also in the overall survival, you see a clear advantage. And also there, the median survival is not reached. And in a later update of this phase 3 trial, you saw that the median survival is about 4 years. So that's a real good outcome. And by the way, the control group now looks to be almost the same as the treatment group, but that was because patients that had relapse were given actually the lutetium dotaocttate as a crossover option, and that really showed also the success in the control group. So you don't have to compare there. And so what does this mean in clinical practice? So we have a patient with various tumors, so in the spine, here in the liver, in spine, in the liver, and this is measured with gallium PSMA. Gallium dotatate. I'm sorry, I made a mistake. I copied this slide. With gallium dotatate, indicating high SUV values, so high uptake values, and the uptake in the liver was much lower than in these tumors. So that was as a reason to give the therapy. And here I showed whole body planar images, so anterior and posterior view, after giving this 7.4 gigabecquerel of lutetium dotaoctutate. And yeah, there was an uptake in the lesions, uptake in kidneys and the liver. It leads to success of the therapy, and yeah, we don't know in this case what doses are really given, so what absorbed doses. We know we give 7.4 gigabecquerel, and that's actually all. So fortunately, it's not always that case that we don't know anything. So here you see an example of a gallium dotaoctutate uptake in a patient with a very large tumor in the thorax, and that this tumor was really creating problems in this patient in breathing, in swallowing, and things like that. So the physician asked us, what dose can we expect from the therapy? So we said, well, if you just have this one SPECT-CT at 24 hours, what the normal situation, we can't hardly say anything, just some expectation value. So fortunately, we were granted 2 additional scans to have an idea on how the kinetic uptake in this tumor proceeded over time. So you see at 23, at 4 days, and at 8 days, we did the scanning. And here you see the outcome of the uptake in the kidneys, in the spleen, liver, and in this large tumor. And you already see that, well, the clearance from this tumor is, well, comparable to the clearance from the kidneys. So it doesn't look that right. So the tumor volume was about 120 ml, and we calculated a tumor dose of 3.5 gray. Well, I don't need to go into radiobiology and dose effect relations to indicate that's not enough, even if you would give 8 or 9 therapies. So that's quite clear. With lutetium PSMA, we are actually in a quite comparable situation. So also there was a phase 3 clinical trial showing that lutetium PSMA, so aimed at treating prostate cancer, was quite successful in treating end-stage prostate cancer patients, but that did not respond to any other therapy before. And so the overall survival may seem quite low with 3 to 4 months additional, but it's really quite exceptional if you compare it to the outcome of most chemotherapy. So don't be that misjudged by this median survival gain. And also there, same situation as in the neuroendocrine tumors. A patient is scanned first with a gallium PSMA scan, showing uptake, well, in this case, a brain lesion, a liver lesion, a large bone lesion, and also all the SUV values are quite high there, so that's really indicative to proceed with therapy in these patients. And well, we see with lutetium PSMA, a high uptake in the kidneys, and also high uptake in the salivary gland. So you can see them here in this image. So this patient was given a treatment with 7.4 gigabecquerel of lutetium PSMA. And again, the only thing I can indicate is the amount of uptake, the amount of activity in the lesions in the kidneys and the salivary glands, and I don't know really what absorbed dose is being given. So aren't there any guidelines or guidance documents to help us to improve the dosimetry? So the ENM Dosimetry Committee wrote a guideline on how to do dosimetry in both lutetium therapies, and indicated, well, you should aim to have an idea on the absorbed dose in organs at risk as the kidneys, salivary glands, lacrimal glands, and bone marrow. But yeah, it does not give you a real idea on what doses in the tumors, for instance, are needed. It doesn't give you a real idea on what treatment planning you could do for these therapies. So I would like to go into detail for a patient group that is now being more and more treated with lutetium PSMA, so that's the early stage prostate cancer. So in this case, there was a study in Radboud University in Nijmegen that they treated metastatic hormone-sensitive prostate cancer. And in that case, the physician was quite concerned not to overtreat and create, for instance, damage in the salivary glands. And yeah, this patient here showed uptake in the lymph nodes, uptake in the normal liver, kidneys, and the salivaries were comparable as I showed before, and this led to doses by the 2 cycles. In this case, the activity was not the 7.4 gigabecquerel, again because the physician was more cautious not to cause any damage in normal organs. And in total, the dose to the lesion was 10 gray by the first therapy cycle and 18 gray by the second therapy cycle. And that led to diminution of this tumor and lowering of the PSA level of these patients. So that already was successful. But look at the uncertainty. We did an uncertainty analysis of the dosimetry. As a physicist, I'm actually a bit embarrassed by these large standard deviation or uncertainties in the value. So it could be anything, is my humble opinion. So, fortunately, there are some more procedure guidelines being published by ENM, and in the most recent guideline is indicated that due to the large interpatient variability, there's a potential benefit from higher activities or giving more cycles for several patients under patient individual dosimetry. So that was quite okay. And in this same document, there are some open questions indicated, and I selected the ones related to dosimetry. And it's stated that it's unclear how retreatment and giving higher absorbed doses in advanced disease will help. So we're not quite there yet to say, well, go for the maximum. Also, the impact of fractionation. So now these therapies are given 4 to 6 cycles with 6 to 8 weeks interval between them. It's not clear what the ideal fractionation scheme is. There is also a tumor sink effect, although in the previous slide I showed with this early stage prostate cancer patient, we didn't see a higher uptake in the kidneys, but other studies do show a higher uptake in normal organs with low tumor volume. And also prior doses by external beam radiotherapy or any other therapy to these patients, the effect from that is not really known. And combination therapies, that's certainly something that should be studied, but the knowledge on that is still minimal. And also a problem is in dosimetry. So consider a typical end-stage prostate cancer patient with multiple metastases at all time points. We can do the dosimetry, but what tumor do we select? So this group in Melbourne came with the idea to have a whole body tumor dose, and that's a very nice concept. And they could show that patients with a whole body tumor dose of 14 gray, or the responders showed a whole body tumor dose of 14 gray. But again, variance in these values is quite large. So to really say that you need 14 gray to have success, that's a different thing. It's more or less the other way around. But it really shows that there is some idea on how to apply dosimetry to improve therapy. And further, as Weibo indicated, we worked on a document by the ICU to have a better idea on what treatment planning schemes can be devised for radionuclide therapies, or as it is called by the ICU, the radiopharmaceutical therapies. And so we came with the concepts of having the normal tissue complication curve and the tumor control curve, and indicating that as knowledge in external beam therapy is larger than knowledge in radionuclide therapy to two gray equal fractions, and trying to translate that from a dose to activity to have an idea on how that would work for the radiopharmaceutical therapies. But again, there's quite some missing knowledge in how these curves really look. And I will show you some examples where we do know some ideas on that. And also in this ICU document, we have a scheme on how to set up a personalized therapy and how to go to more dosimetry guided therapy. So first of all, you have an idea on the specific uptake of the compound you're looking at by measuring the PET images, and then try to derive some ideas on how the therapy situation would work out, and also with the feedback of the first therapy cycle. There you really measure and try to optimize the activity to get a better outcome of the therapy. And well, it's more or less a loop trying to improve the outcome, but also there it's more a theoretical exercise than that we really can give sound figures on what to take into account. And as well, we tried to improve our ideas. A group, the RPT Tech, came together with the idea to gather the existing dosimetry data together with toxicity and efficacy data on radiopharmaceutical therapies to come with a better knowledge on what dose effect curves we could expect. What we found out quite soon is there's hardly any data, real sound data available. Certainly not prospective data, mostly retrospective data, and yeah, that was really something to work on. And also the dose reporting can vary quite a lot among various investigations. So that is something, yeah, to improve. And well, what we did come up with is some ideas on how to improve the dosimetry guided phase 1 trials, to get some better ideas from that. And yep, no, other way around, yeah. And yeah, we try to get some ideas on how dose escalation studies, which now are mostly based on how normal drugs are being escalated, so amount of drug, and yeah, that's used in as the activity escalation drug, as I showed with this phase 3 trials, and essentially you want to go to escalation in absorbed dose. And yeah, it's a very nice document here to give you an idea on how to come to some better outcome of clinical trials. And this brings me to the essential question in setting up treatment planning for radiopharmaceutical therapies. Do we have to go again through all phase 1 to phase 3 trials, and indicated here what I mean with these trials? So that's the clinical medical approach. So proving superiority of dosimetry-guided treatment planning over the traditional 4 times 7.4 gigabecquerel, or can we go for the physics and radiobiology approach? So first of all, be sure that we have an accurate absorbed dose, so the 18 plus or minus 12 gray should really be improved. And also have a better idea on the specific dose-effect relations to expect for these therapies. And yeah, up to now, we are building on knowledge from external beam radiotherapy to really come up with some dose-effect curves. And one of the aspects with what's now being considered is to treat as high as safely achievable. So treat, and abbreviated to AHASA, and treat to the maximum tolerated absorbed dose in organs at risk. And for bone marrow, that would be 2 gray, for kidneys 40 gray with yttrium-90, that is, and for salivary glands, we're not quite knowledgeable on radiopharmaceutical therapy, 20 to 25 gray, as known from external beam radiotherapy. So to give you an example on how this is done in the clinic is iodine-131 therapy of thyroid carcinoma is sometimes being given by a prior scout dose of, in this case, 9 megabecquerel of iodine-131 to know the uptake in the total body and uptake and the clearance of the activity from the blood. And by that, we can calculate the beta dose from the blood time activity curve and the gamma dose from the whole body time activity curve. And by that, we could calculate that these patients could have a activity of almost 23 gigabecquerel to reach this maximum tolerated dose of 2 gray. I can imagine that you think, well, this is quite high, and it is quite high. So it's really a challenge for radiation protection to have these patients in the therapy ward. But it's done, and it's quite successful. So the consequence is that these patients do not need to be retreated. So, and I was indicating the tolerance dose for kidneys as 40 gray, and this is found in response of the kidney toxicity found after yttrium-90 DOTA-TOC therapy. So DOTA-TOC is a comparable peptide as DOTA octreotide, so also aimed at treating neuroendocrine tumors. And after yttrium-90 DOTA-TOC, they found a curve which was slightly shifted from the curve that was known for external beam radiotherapy, and this shift could be explained by using the biological effective dose, which takes into account the linear quadratic model. And a very important factor is that for these irradiations, in comparison to external beam radiotherapy, that you need to know something on the repair half-life of sublethal damage. Well, fortunately, there was some information on that, on this repair half-life from animal experiments, but you see here the 2.8 hour which we took to calculate this BED can be anything between 1.2 and infinity. So we have some freedom in choosing it. But the advantage of considering this is it shows you the advantage of sparing the kidney by giving either external beam in 2 gray fractions or giving the dose in a longer half-life. So the 2 green curves compare a dose given with an effective half-life of 12 hours to an effective half-life of 96 hours. So this seems quite reasonable. So a clinical trial was set up in Sweden to treat patients, first of all, several cycles of therapy with this 7.4 gigabecquerel until a BED of 27 gray was reached. That was a more conservative threshold. And if these patients did not show any direct toxicity, these patients were treated until the dose to the kidneys reached a dose of 40 gray. So yeah, and the outcome of this clinical trials showed that there is a clear advantage in patients that have a kidney dose above 29 gray in comparison to patients that have a dose to the kidneys below 25 gray. So that's really a nice indication on how it works. The next thing is, of course, that we need to know what dose to the tumor is really needed. And I'll jump over to another therapy, yttrium-90 radioembolization of liver cancer showed the advantage of treating according to a personalized dosimetry scan. So the aim was to treat the tumor with a dose to 205 gray or more. And there is a clear advantage in survival. So almost a year, no, longer than a year, in comparison to patients that were treated to a safe dose to the liver at 120 gray. So there is a clear advantage in doing personalized dosing there. Also, there is quite some evidence that with neuroendocrine tumors, we need doses above 100 gray to show a diminishing of the tumor volume after therapy. And yeah, what doses do you need to really see some success? So another phase 2 trial showed that patients that had a tumor dose with the first therapy cycle above 35 gray showed a better outcome than patients that were below. So that's already also a nice indication. But above 35 gray, so is 200 gray, 250 gray needed? That's the next question. So a group in Montpellier looked at the tumor volume decrease or, well, change after lutetium dodeoxycholic therapy. And they came up with this very peculiar curve, almost showing an increase of tumor volume at doses above 120 gray. So I was quite puzzled by this curve, and I did my own calculations to the data. Unfortunately, a linear exponential curve explained quite well that there's no real upward curve, but still we see a quite scattered outcome, indicating nevertheless that 100 gray, or say perhaps 120 gray, is the dose you need, and any additional dose does not really deliver any additional effect. So that's something we have to discuss, what's causing this saturation of response. That's my first explanation is perhaps it's inhomogeneous dose delivery, but yeah, I'm open for any other suggestions on that. So how can we then go to some more personalized therapy? So in the same group from RPT Tech came up with some suggestions on how to improve the fixed activity dosing for lutetium PSMA, depending on the uptake as shown with PET imaging. So for patients with an SUV above 10, you can go the traditional way of giving 7.4 gigabecquerel and additional dosimetry. It's not really essential to do. But patients below 10, a factor 10 in SUV, why not give them twice the amount, so 14.8 gigabecquerel. In that case, you really need dosimetry to be sure that you're safe and not over-treating, for instance, the bone marrow and salivary glands. So that, under guidance of dosimetry, it's suggested to proceed in this kind of therapy. And I think my time is almost finished, so I'll skip to the conclusion. I had some additional slides on, because how to reduce the number of time points in doing the dosimetry and using zirconium PSMA to have some better idea, because physicians, they always complain having these patients 3 to, well, in some cases we even have 5 scan moments to have an accurate time activity curve is too much burden for them and for the patients mostly. And yeah, in comparison to external beam radiotherapy, it seems to me not too much, but yeah, it's of course how it's being told to the patients by these physicians. So if they don't believe it, then it won't be there. So the conclusion is, I hope that I showed that there is some importance of doing dosimetry, and there are some initiatives to realize a more patient-specific treatment by doing dosimetry. The approach using the physics and radiobiology knowledge is now more or less being tried, but I can imagine that the moment we have a clear indication of advantage in some therapy, we'll need to have additional clinical trials, although these trials, certainly phase 3 trials, to compare dosimetry-guided treatment versus the fixed activity treatment will be quite costly. That because yeah, you need quite a lot of patients to really be sure that you're having more benefit. And with that, I would like to thank you all, and happy to answer one, perhaps 2 questions.
Yeah, thank you very much. Because of time, feel like maybe one quick question, if some urgent question. Yes, of course.
Hi, thank you for a very nice talk. You mentioned the combination of therapy, so that's combination with the external beam therapy and radionuclide therapy. And how do you calculate those then?
Indeed, we have some patients. So the most common is that after yttrium-90 radioembolization, some liver tumors come back, and there were some patients that these liver tumors were really painful. So the radiotherapy department said, well, we want to have a palliative treatment of this tumor. And it was quite troublesome to compare the doses we gave to doses with radiotherapy. our most convincing argument was that the targeting of the yttrium-90 microspheres was really confined to the tumor region, and there's hardly any dose given to normal liver tissue. So that was our argument against going too much further into the radiobiology, but I agree that giving, so it would be ideal in some cases where you don't reach the high enough doses to expect efficacy, to combine these therapies, to combine radiotherapy and some radionuclide therapies, but we don't know really now how to compare the dose by radionuclide therapy to the external beam radiotherapy. That's certainly something to be studied further. Yeah.
Yeah, we have an expert here. Yeah, external therapy, dosimetry. Maybe we can talk later for the joint task inside EURADOS. Yes. Thank you very much again, Mark, for the very interesting talk. The second expert is Nina Petoussi-Henss, is from Germany, Munich, from BFS. But before that, she worked in Helmholtz Center, Munich, even earlier GSF Forschung Center, a research center. As I started my career in Germany, I met Nina 26 years ago. I learned a lot of Voxelphantom setup and also dosimetry calculation from Nina Petoussi. Please, Nina.
Thank you. So, good afternoon, everybody. And I would like first to thank the organizers for inviting me and for giving me the opportunity to give you some insights of the ICRP work, and in particular the work of two task groups who are occupied with patient dosimetry for radiology and diagnostic nuclear medicine. I'm going to talk for the next 20-25 minutes about dose coefficients, so I would like to remind you what a dose coefficient is. A dose coefficient is a quantity which, when we multiplied it with a measurement of radionuclide intake or ambient dose equivalent or fluence or gamma area product, it yields to dose to an individual. So the first part of my presentation today will be to introduce you at least some aspects of the work of a task group which is developing dose coefficients for common X-ray imaging examinations. And I would like to acknowledge here my co-chair and also all the members of the task group. We have a large and very international membership from countries from the US, Europe, and Asia. Some people are also members of EURADOS. And from the members, 2 are radiologists, and we have 5 medical physicists and several people who they are doing modeling work, who they are doing the simulations. And the collaboration of this different expertise are very important for the work. So why ICRP is doing this project? Coefficients relating absorbed dose and measurable quantities have been calculated using Monte Carlo methods for the last 40 years. But because there is no gold standard and no agreed set of phantoms, results are not directly comparable. And just to give you an example, in 2019, in a publication of the National Council of Radiation Protection in the US, effective dose for CTs have been presented, And these effective doses were based on simulations obtained with MERT-type mathematical phantoms. Just a little bit earlier, there were doses, similar doses for CT presented from PHE, which is now our hosting organization. And these doses were based on the ICRP reference voxel phantoms. The outcome was that the UK CT effective doses look higher than those from the US, although the UK dose length products are in general lower than in the US. So here it seems that there is a problem. So the scope of the ICRP is to provide reference dose coefficients using the ICRP methodology, which is worldwide recognized and accepted. And this word reference means that the conditions that these dose coefficients have been developed are exactly defined, and there are some reference assumptions behind them. So the aim of this work is to perform Monte Carlo calculations on a series of references imaging examinations using the ICRP reference voxel phantoms and the ICRP methodology. In this methodology, it is included the way that the effective dose is currently defined and estimated, and then to report organ absorbed and effective dose coefficients. We are working in 5 work streams. Because of time constraints, I will address only 3 of those. So I will start with radiography. So you see in this slide the projections that have been selected for consideration and for simulations. And this selection was made based on the frequency of these examinations. These frequencies recorded in the UK, in Europe, in the US, and in the UNSCARE. So for every of these procedures to be simulated, the anatomic landmarks have been defined from the radiologist, who also defined the related field parameters. And then it was a task of the modelers to translate these instructions to coordinates for the Monte Carlo calculations and perform these calculations. The calculations were carried out for 1 kV energy interval, and this has been a generic method that, will allow the user to construct its own X-ray spectra, and we chose this generic method in order to address the big variety of spectra used around the world. For those users that they don't want to construct their own spectra, we are giving also about 800 data sets from some selected Bremsstrahlung spectra, and these are reported as doses per camera area product and per air camera free near 1 meter distance from the source. So the data include organ doses separately for male and female, and also the effective dose. The draft report on radiography is already it's written, and it will be online for public consultation next month, so I will be happy if you have a look and comment. The data will be accessed as ASCII file, And also the data for the Bremsstrahlung spectra will also accessible via the ICRP viewer, which is an application for mobile devices. And it is developed by Martin Andersson and includes also other exposure conditions and other dose coefficients that they have been developed at the ICRP. So now I will move to computed tomography, which is of course a very interesting modality for dosimetry, since 62% of the annual collective doses are attributed, annual collective dose from medical exposures are attributed to CT. And I will try to explain to you the method, the approach that the task group is taking for this task. So rather than developing a tool that is specific to any one CT scanner or to a predefined set of scanners, the task group has developed a so-called ICRP representative scanner based on the characteristic of 13 scanners. And this is actually an achievement of Jan Jansen, who is working for our host here. Jan has a non-disclosure agreement with 4 CT manufacturers to model 13 CT scanners. And for each scanner, he was able to obtain the technical parameters for doing the simulations. This is difficult to know this parameter. And altogether, he simulated 102 separate operating conditions for each of the male and the female adult phantoms. And with this data, the ICRP CT scanner has been defined. And just to give you an idea of the results, you can see here on the y-axis is the effective dose, which actually is not the effective dose, is the contribution of the male phantom to the effective dose. And on the x-axis is the height of the phantom. The 0 is at the bottom of the trunk, and 95 is the head, and minus 82 on this side, there are the feet. So this, each point of these curves has about 102 simulations, 102 conditions. And there is one black curve that I know this might be a bit difficult to recognize in the graph, which is the ICRP scanner. So what I wanted to show is that the ICRP scanner is well in this range of the data of the other scanners. So with this ICRP scanner, simulations were done for all the 12 ICRP voxel reference phantoms, the 2 adult and the 10 pediatric ones. And the results can be made representative for any scanner by entering selected CDDI vol and tube voltage of the protocol and the relevant CDDI phantom head or body. The results can be accessed with the ASCII files as well as with the special GUI, which has been developed for this purpose, and is going to be based and maintained on the ICRP domain. So the user has to enter his own parameters. There is also the choice to study the effect of tube current modulation. And yes, the user enters his own protocol, so we do not recommend any protocols. Okay, let me check the time. Good. So I'm moving now to fluoroscopically guided interventions. So for FGI procedures, all FGI procedures are tailored to the individual patient. And therefore the organ dose is dependent on patient side, procedure complexity, operator factors, and equipment parameters. There is also a wide range of caps for every procedure, and it's not possible to define a reference examination on a reference phantom. So we had to think here for something else and to divert from the concept of the reference patient. So instead, we are using radiation dose structure report of a large number of patients. We have defined 11 FGI procedures to address, and for every procedure we will have about 1,000 patient data. This data, they all come from hospitals in the US. Actually, this part of the project is totally in American hands. And we are using this anonymized patient data to investigate the possibility of using them from multiple cases of the same procedure to produce a typical or average organ and effective dose. The dose calculator of the National Cancer Institute dosimetry system in the US is used for this purpose. This software was initially developed for reference adults only, but it has been extended to include the non-adult reference phantom library of NCI and University of Florida. So each patient will be mapped to one of the 193 male and female and different habitus phantoms. And then the procedure technique parameters will be then used to reconstruct the organ and effective doses. And we will evaluate the average or representative dose by looking at the 50th percentile. So now I'm moving to my second task group, and the second topic, which is dose coefficients for patients in diagnostic nuclear medicine. So this task group is chaired by Augusto Giussani, who is in working group 7, and a couple of other people like Dietmar Noske, and I think they are members of EURADOS. So the ICRP has previously issued numerous publications with such dose coefficients, and the latest were compiled to 2015 in publication 128. And the primary objective of the task group, of this task group now, is to revise these dose coefficients in accordance with the latest dosimetry guidelines provided in the current ICRP recommendations of 103, and also considering the most recent advantages in biokinetics, phantoms, and dosimetry. So revision since the last issue of this type of dose coefficients. A large revision of biokinetic models has taken place, and also some new biokinetic models have been developed for new substances and new radiopharmaceuticals. There are newer radioactive decay data, also the reference voxel phantoms that are substituted to mathematical phantoms. This is the point. The phantoms are used for the calculations of the specific absorbed fractions, which is the main quantity of dosimetry quantity for estimating the doses. And there are also considerable progress for estimating the dose for the skeletal tissues. Also, new tissue weight factor, radiation weight factor, and tissue factors, and the male and female averaging. The biokinetic models, a very important part of the work of this task group. So the goal is to move from the current descriptive biokinetic models to more physiologically realistic compartmental models. The descriptive models, like those used in publication 128, simply indicate how much activity is deposited in an organ, and there's no real interaction between the different compartments. The new models, which are systemic models, they have the blood compartment, which allows the interaction of substances from the one compartment to the other, and they also have described the excretion in a physiological way. Another interesting and important point of the new models is the bladder model. Bladder is an important organ in nuclear medicine, since many radiopharmaceuticals have a high excretion through urine. So the previous model was static, and now a dynamic urinary bladder model has been developed, which assumes a stepwise emptying of the urinary bladder at discrete times. And different emptying schemes can be implemented, and in this way simulating realistic investigation protocols. Also, the change of the shape of the bladder according to how it's filled is taken into account, and different specific absorb fractions are calculated with Monte Carlo for the different shapes of the bladder. Some features of the specific absorb fractions used, I would like to mention, as I said, based on the voxel phantoms. For the first time, electron absorbed fractions were explicitly computed with Monte Carlo codes. That was not the case before. Also, the integration of phantom-derived SAFs with those derived from stylized models of the alimentary tract and respiratory tract. So some tissues of the alimentary and respiratory tract, they're very fine and they're smaller than the voxel resolution. That's why the specific absorbed fractions of these tissues are calculated separately, and then they're combined with the voxel-based calculated SAFs. Also, another novelty is the interpretation of the reference masses. Now the reference masses are interpreted as being exclusive of the blood content, the reference masses that have been published in publication 89. So now they're interpreted as exclusive of blood content, and the blood content had to be added. So putting all those things together, the new biokinetic and dosimetric models are implemented at the software IDAC, which is a free software for diagnostic nuclear medicine purposes. And organ-absorbed doses and effective doses are coming out of it. I would like to mention that for these dose coefficients, that actually all dose coefficients that the ICRP is developing, there is a big QA activity. This is one of the reasons that the development of these coefficients is really a long procedure, but we think that it is important. Okay, now I've finished almost, and I would like to finish with some closing remarks. I would like to remind you that the effective dose is an indicator for stochastic risk, but it is not intended for the assessment of risk of individuals. Because of the uncertainties in the low dose range, underlying approximations and simplifications and sex and age averaging. However, in practice, it is often used as a first estimate for risk, for example, in medicine. But this has to be made really with caution. The difference in effective dose coefficients that you will notice when you see our results relate only to the differences in the physical size and organ masses of the phantoms and do not address differences in detriment perceived because of the sex and age averaging of the tissue weighting factors. Effective dose could provide an approximate indication of possible risk with additional consideration of individual patient phantoms, but large uncertainties remain. Also, the population group of the patients is, of course, not a group like the general population. Doses are assessed using models and measuring quantities, and these models seem to fit the purpose of radiological protection. New anatomical models based on polygon meshes have been developed the last years, which are more realistic. But despite all the efforts that we all have made the last years or decades, doses are still calculated to a reference person in a reference exposure situation. Individual models are developing fast, and they're going to develop even faster with artificial intelligence. But to be useful, they must be developed in parallel with an individual risk assessment methodology. Otherwise, they don't really bring us forward. So thank you very much for your attention.
Thank you very much, Nina. If you have one or two quick questions.
I did not exceed my time. I start later.
Yeah. Okay. Yes.
Okay.
Thanks for a very interesting presentation. Obviously, ICRP are in the process of revising, producing new recommendations, and they're likely to change WTs in particular, I should think, the next evolution of the recommendations, and potentially WRs. Will all these data be stored in a way whereby you can just re-evaluate them from the computations and not need to recompute them?
Good question. Yes, yes, and we we score every organ, so we have all these organs, but I anticipate that there will be also maybe some other tissues or part of the tissues defined that we do not have.
Yes, the remainder.
For example, for stochastic effects this is not important, but for sure it's going to be something around heart for the cardiovascular, but these are tissue reactions. Yeah. But it will be that there will be some other tissue, and that's...
Well, it'll keep Jan going another decade.
Yes. Additional questions? I have a question. Do you have some plan for because you introduced the diagnostic nuclear medicine, radiopharmaceuticals. Is there some plan in the future for the radiopharmaceutical therapy dosimetry assessment?
Well, there is a separate task group with, I think, who is working on therapy, but I'm not very familiar with its work.
Yes. If there's no further questions, I thank you, Nina, again very much. Yeah.
Thank you.
The third expert is Dr. Hanna Koivunoro. I think she's working in Neutron Therapeutics in Finland, Helsinki, I think, as the chief medical physicist. I think you started from your career already in this BNCT until now. Yes. Thank you very much. You introduced us, the dosimetry for the BNCT. Thank you.
Thank you. So, good afternoon, everyone. So, I will be speaking about dosimetry for BNCT. But very first, I will just go through BNCT basics and the current status. So, why we even need the dosimetry. So, boron neutron captured therapy, BNCT, works so that first the patient receives boron 10 enriched boron carrier infusion. It takes typically 2 hours to infuse the patient. When the boron accumulates, of course, everywhere in the body, first spreads everywhere in the body, accumulates in the cancer cells. In some countries, neutron irradiation is given during this boron infusion, but in some countries we wait 1 to 2 hours after end of infusion and then position the patient in front of epithermal neutron beam and irradiate either from one direction or 2 directions. We used fixed beam for irradiation, so we rotate the patient if we want to irradiate from 2 directions. And what happens at micro level, so boron 10 atom sits inside the cancer cell. We irradiate that with the thermal neutrons. I mean, the neutrons are thermal at the location of cancer cell. And boron 10 splits into 2 high LET particles, alpha particle and lithium-7 recoil. They are high energetic particles with very low short range, so they deposit all of their energy within range of 1 cell diameter, and that's why they have high RBE of almost 4, and they are really high LET particles. BNCT requires very high intensity epithermal neutron beam, meaning about 10 keV neutrons, and earlier only nuclear reactors were able to produce such a beam. Because we want to filter all photons and thermal neutrons out of the beam, and also we want to have very small fast neutron contamination. So neutrons above 10 keV of energy, they start to have toxicity in tissues. So luckily nowadays there are several vendors that have developed accelerators that can produce neutron beam for BNCT. So as mentioned, BNCT is biologically targeted high LET radiotherapy. So there are 2 reasons why it is kind of a desired treatment. for certain cancers. So first reason is that this BPA accumulates in the cancer. So here we can see one PET image, fluorine-18 labeled boron carrier PET image, where we see about 5 times higher accumulation of boron in cancer than in surrounding brain. Also, cancer cells are more sensitive to BPA, BNCT than normal cells, so we have more dose gradient because of that. We know that high-quality radiation is, at least in theory, effective against radiation-resistant cancers, and because of the dose gradient, we can administer BNCT as irradiation, or near or within radiosensitive tissues such as brain, spinal cord, optic nerve, liver, lung, like you know. And BNCT is given either in single fraction treatment or sometimes it's given once or twice. And we have seen very promising clinical results with reactor-based BNCT in several quite difficult cancer indications, and we have seen good results in combination of BNCT and chemotherapy and BNCT with normal radiotherapy, and we have also seen very good results when we irradiate large or rapidly progressed tumors. At the moment, several BNCT accelerators are under commissioning or under clinical approval around the world. So here I have this map from IAEA, not very pretty map necessarily, but all those colored dots show all 33 BNCT facilities that are either under construction or under operation in the world. So the North America is not in the map because there is not any solid plans yet. There is interest, I have to say, and only 4 out of these facilities are anymore reactor-based, and 29 are accelerator-based systems. Biggest number in Asia, but also some in Europe and Argentina. Altogether, there has been only about 2,000 patients who have received BNCT, and that's quite a small number considering that BNCT has been given since 60s. However, this number is increasing very rapidly. It's mainly high-grade gliomas and head and neck cancer, but also other indications. So here is just as an example, accelerator-based BNCT facility installed in Helsinki, Finland. So with the accelerator, you first have typically proton beam. You need quite low energetic protons, in this case 2.6 megavoltage protons that are accelerated to very high intensity, so 30 to 40 milliamp beam. These protons are guided to the treatment room. There is a beam shaping assembly. And inside this beam shaping assembly, there is rotating lithium target. And this lithium target is used to produce neutrons. So when these 2.6 megavoltage protons hit lithium target, about 700 keV neutrons are produced, and they need to be slowed down to 10 keV beam. And that's why there is this beam shaping assembly. So we don't have gantries in BNCT yet, because typically only one field is needed or 2 fields. So we have thought that it's more maybe cheap to rotate patients than develop the whole gantry. But of course, it's also possible with the accelerators. So instead, we have a robotic patient positioning system in the treatment room with 6 axes, and also we have a CT scanner on rails that can be used to verify patient positioning. And the CT scanner needs to be on rails, and there is a neutron shielding door front of the scanner during the irradiation, because pretty much all the electronics are very sensitive to neutrons and they would be destroyed. This robot is not destroyed by the neutrons, luckily. It's neutron resistant. This type of accelerator systems has been installed in Helsinki and also in Japan, in Shonan Kamakura General Hospital. And both of these systems are very soon operational, so we have fully commissioned the Helsinki system, and we are now applying license for clinical trials and really hope to get started next fall. So in BNCT, dose is a little bit complicated thing because these thermal neutrons that are needed for the treatment and interact with the boron 10, they also interact with the nitrogen in tissue, and there is nitrogen in every tissue. And when thermal neutrons are captured by the nitrogen, they produce protons and recoil carbon ion, and those two have high RBE factor, almost 3. Luckily, it's very local dose, range is very short because the energies are low of this proton and carbon, but it's pretty much like an end of Bragg peak situation. That's why the RBE is high. Also, thermal neutrons interact with the hydrogen in tissue and cause 2.2 MeV gammas. So these gammas are everywhere, pretty much everywhere in the patient. So that's not nice, but we can live with that. Also, so thermal neutrons cause 3 dose components in BNCT. And then there is always little amount of fast neutrons in the neutron beam. So here I have plotted the depth dose curves of these 4 dose components, assuming same amount of boron, but we measure in blood, and we assume in normal brain during the treatment. So we see that the absorbed physical dose comes mainly from the boron dose, then photon dose is about half of it, and nitrogen dose half of the photon dose. And fast neutron dose is quite small, only higher in the skin, and then rapidly decreases. But in the clinical case, we need to multiply all of these dose components with the RBE factors, and we call boron RBE factor CBE factor because it depends on the boron compound what is used. Nowadays, only BPA is used, so it's quite easy. So here are the RBE factors we use to get these dose distributions in the tumor and tissue. So we see that the red depth dose curve represents the tumor dose, and black represents the normal tissue dose. So in any location here, if we have cancer cell, it is probably getting as high dose as this red curve shows, but if there is a normal tissue at that location, it receives this black curve dose. And thermal neutron dose components, they cause 95% of the tumor dose after we go 5 millimeters deep in the tissue. So because we use epithermal neutrons, there is not that much dose within first 1 centimeter or something like that. So if we treat superficial tumors, we use bolus to first like thermalize neutrons. So BNCT dose to patients is derived as combination of the neutron fluence and administered boron compound. So as I mentioned, now only 1 boron compound has been used, but there are several under development, but that's the more expensive and complicated situation. I still hope that we will see those new boron compounds soon. Anyway, BPA is already quite good. It's amino acid which accumulates in any rapidly dividing cancer cells, we have learned. It can be labeled with fluorine 18 for PET imaging, and we can estimate tumor uptake before BNCT. However, we don't really know yet if this PET image shows the same distribution as what we have during the treatment, because during treatment we have very high dose, very long infusion. And also we actually don't think that it's so important to do PET imaging because we have learned that pretty much all the rapidly dividing cancer cells uptake boron. So it doesn't really change the situation. The blood boron concentration is measured during the treatment. We can measure it with about 5% uncertainty, and we estimate tissue to blood concentration ratios for other tissues based on published data. So, and then the second parameter in BNCT is the neutron fluence and neutron dose, and characterizing those is responsibility of medical physicists, and all of these 4 dose components must be well characterized. So for boron and nitrogen dose characterization, because they are both induced by thermal neutron fluence, we need thermal neutron sensitive detector. For photon dose, we would like to have a neutron insensitive detector, which is only photon sensitive there in the neutron field. And then we have also fast neutron dose, which is the most problematic to measure because it's the highest on the phantom surface. BNCT dose peaks at about 2 to 3 centimeters depth, and that's where we have defined 2 centimeters as reference depth. So there is no accepted standards of code of practice for BNCT dosimetry yet, which is quite a problem because we would like to standardize delivered dose across multiple institutions and countries now that BNCT is again growing. There are lots of publications and dosimetry methods and data, and also 3 unofficial dosimetry recommendations. 2 of them are 20 years old, one published by IAEA and one published by European SMT project. So that was mainly like opinions from Europe. And then there is one newer guideline, but it doesn't really give recommendations, but it's just kind of a collection of information about BNCT called Advances in Boron Neutron Capture Therapy, and that was published last year. So one question, should we measure in air or in phantom? So as we know, in clinical dosimetry nowadays, delivered dose should be defined in the phantom, and we think that also in BNCT, we should naturally define BNCT dose components in the phantoms. However, there are some exceptions. So IAEA has recommended certain parameters for the epithermal neutron beam quality. So there are recommendations how much the thermal neutron, fast neutron, and gamma contamination is allowed in the neutron beam. And the only way to measure that is in free beam. And also fast neutron dose, as I mentioned, it's problematic because it decreases very fast when you put anything in the neutron beam. And that's why it is best, in my opinion, to measure fast neutrons in free beam, because then the neutron beam is, and the fast neutron part of it is undisturbed. So activation detectors are the reference method for thermal and epithermal neutron fluence dosimetry, and also recommended by this European old recommendation. We like to use gold and manganese diluted foils. They are very thin and invisible to neutrons. Manganese foils measure thermal neutrons only, and gold also epithermal neutrons. So you can verify both parts of neutron spectrum with these manganese foils. And here I have plotted a depth curve, distribution curve, scaled to same unit area of gold reaction rate, and then manganese reaction rate, boron dose, and thermal neutron dose. And we see that the manganese reaction rate, boron dose, and thermal neutron dose, they are exactly behaving same way in the phantom. And in practice, we place these manganese and gold foils together at like same depth. They are thin, only 0.2 millimeter thick in the phantom, either in solid phantom for daily QA or in water phantom for better characterization of the field. And we need to irradiate them quite a long time, 30 to 60 minutes, and then we read them with the germanium detector. We can also read these 2 foils at the same time because the activation gamma peaks are quite well separated, so they don't disturb each other. We read them about 30 minutes, so half-life of the gold peak is 2.5 days, and manganese peak only 2.5 hours, so we are a little bit we don't have too much time with the manganese reading. So here's just one example of how well this measurement method works. So I have plotted some water phantom measurement and simulation results for reaction rates, gold and manganese, and measured reaction rates are within ±2% from this simulated. So there's also an alternative way to measure thermal neutron flux. So you can only use gold and forget about manganese if you place gold inside cadmium cover, because cadmium captures all the thermal neutrons from the around, and then you can also define your neutron flux that way. And here are some plots from Japan. That in Japan they use this as a reference method for thermal neutron flux verification. And as we see from this depth of curve, again the experimental and calculated reaction rates are agreeing very well. Yeah, okay, my plot has shifted somehow. It's maybe from my Mac to Windows world. Anyway, just one point that, like I have shown already, the neutron activation reaction rate of these materials in neutron field are proportional to neutron flux and also thermal neutron dose if you use thermal neutron sensitive materials. And these reaction rates of manganese and gold, they can be converted actually to nitrogen dose, nitrogen capture reaction, and also boron capture reaction if you use empirical relation published by Freudenreich. And also when you so you can use manganese and gold reaction rate measurements to define gold in boron and nitrogen dose rate. And that's actually what we have done when we have commissioned our dose calculation system. And then let's speak about ionization chambers in BNCT. So we use dual ionization chamber technique, which has been described in ICRU report 45 for fast neutron beam dosimetry. This is again quite old method. So in this method you use two cylindrical gas flow chambers of equal size made from different materials. So then they respond to different parts of the radiation in this mixed field. We use X-radine cylindrical chambers, T2 and M2. And this M2 chamber, it is the photon absorbed dose detector. So it has magnesium shell and wall, and we flow argon gas. Alternatively, you could use graphite chamber with carbon dioxide gas. And this chamber is assumed to be neutron insensitive and or have very low neutron sensitivity. And then this T2 chamber, it is made from A150 plastic, and so it is tissue equivalent, and we flow it with methane-based tissue equivalent gas, which has very similar elemental composition as A150 plastic. So it can measure all three BNCT dose components together. So it's total dose, you can't separate them from that one chamber. However, the intention in dual ionization chamber technique is that this photon dose is subtracted from the total dose measured with the tissue equivalent chamber, and that way you can separate neutron dose and photon dose. And furthermore, if you have some way to know how much there is thermal neutron dose, you can define fast neutron dose by subtracting from the total dose the photon dose and the thermal neutron dose. Sometimes lithium shielding gap has been used in front of, like around the T chamber, so that you can filter out the thermal neutrons. This formalism is quite simple. Unfortunately, these chambers are still calibrated in cobalt-60 beam because we don't have a reference neutron beam, which has increases uncertainty of the system, of the method. And also one problem here, or that increases uncertainty, is the little bit unknown in the sensitivity, relative sensitivity of these chambers to neutrons and photons. But I'll speak about that a little bit more. So we assume that photon sensitivity of both of these chambers is very close to 1. The photon energies in BNCT are quite similar, not that much different than in cobalt-60 beam or Linux. But the neutron sensitivity, okay, like I said, we assume that the neutron sensitivity is 0 or very close to 0 for photon chamber. And then the neutron sensitivity for D chamber, this equivalent chamber, that's a little bit more complicated issue. So because it's relative sensitivity of that chamber to photons in cobalt-60 beam and neutrons in neutron beam, it needs to be simulated. Actually, this cobalt-60 part of the equation, those are just constant, so that doesn't need to be simulated. But the neutron part, it is energy dependent, because the kerma and also energy required to produce an ion pair in T gas in neutron beam, it's energy dependent. So we need to define this relative neutron sensitivity of the chamber for each measurement point. When we have thermal situation where all the neutrons are thermalized, then it becomes constant. So there are some problems with the dual ionization chamber method, and the first problem is that these neutron insensitive chambers are not neutron insensitive always. So we have found out that this magnesium argon chamber, not all of them, they are individuals, but sometimes they are very neutron sensitive, and the neutron sensitivities have changed along time. So we have seen huge amount of difference. So in my opinion, this magnesium argon chamber is not very good idea to use. So we have problem. We don't have very good chamber to measure photons in neutron beam without neutron sensitivity. So there's the alternative photon dose determination can be done so that we measure the total dose with the T chamber, then we use the nitrogen dose definition with the foils, so we measure nitrogen dose with the activation foils, and then we just use simulated fast neutron dose component, and then we subtract nitrogen dose, fast neutron dose from total dose, measured total dose, and then we have almost experimentally defined photon dose. And actually, when we go in depth dose curve to 40 millimeters, 4 centimeters, our fast neutron dose is 0. So then it is actually experimental. So here I have plotted depth dose curves, measured and calculated in Helsinki. So the highest dose here, that's the T chamber measurement dose. So it's the total dose to muscle without boron. Calculated and simulated, pretty good agreement. And this green curve, that's the nitrogen dose. So dots are the measured foil measurement, the dose defined with the foil measurements, and the curve is calculation. So again, pretty good agreement. Then this is simulated fast neutron dose, and I have subtracted nitrogen and fast neutron dose from the total dose. I get experimental photon dose, and it's agreeing actually pretty well with the simulation. So quite okay. Alternatively, in Japan, they use TLDs for neutron measurement, but then for photon dose measurement. But you need to use neutron shielding because TLDs are sensitive to neutrons as well. So they have published uncertainty of plus minus 10% for this simulation, and pretty good agreement between measured and calculated photon dose distributions. So for fast neutron dose and fluence, as I mentioned, there's no direct method to measure only fast neutron dose for BNCT. So again, if you have reliable way to measure photon dose, you can again do subtraction from the total dose and you get your fast neutron dose. But then there's problem because fast neutron dose decreases very fast when you go to the phantom. So another possibility is to define neutron spectrum in air. And you can do that with multi-activation foil method, so have several foils with different energy responses and do unfolding of the spectrum. Or then you can use some kind of a proton recoil detectors, like proportional counter with hydrogen gas or scintillation spectrometer with organic scintillator. And we have used this multi-activation foil detector system. And here is the neutron spectrum for reactor, the black one, and for accelerator, the red one is the measured one, and the blue dotted line is the simulated. And we get quite nice results. And this is almost my last slide about the uncertainties. So in this new IAEA publication, there is a statement that several uncertainty analyses have concluded that the reasonable uncertainty in total dose delivery in BNCT is 7%, 1 sigma, excluding the uncertainty in the boron concentration and tissues. And based on the methods we have used in Helsinki, which is the diluted manganese and gold foils and the chamber, that's something what I can also say about the uncertainties of the measurement methods. So we are around there. We can't do better at the moment, but maybe that's okay. In free beam spectrum, the estimated uncertainties are a little bit lower, smaller for fast neutron flux and epithermal flux, but for thermal neutron flux we have high uncertainty because we don't have thermal neutrons in the beam very much. So as a summary, BNCT dosimetry is rather complicated. Accuracy of existing dosimetry methods have room for improvement. Activation detectors are reliable, but rather time-consuming to work with, at least in clinical practice. And also one thing I forgot from here, we are still missing like good photon-sensitive, not neutron-sensitive detector. As BNCT is becoming more common radiotherapy, harmonizing the dosimetry practices is crucial. And that's why we have started this dosimetry code of practice planning, and we have now written like a first short report on that, some ideas, and it is going to be published very soon. So it's a team of now in the beginning me and one British medical physicist who have very long experience, and we have also a Japanese colleague in this team. So thank you very much for your attention.
Thank you very much. Some question? Yes.
I think a very, very interesting presentation. I hadn't realized exactly how much BNCT was going on. With regards to estimating the fast neutron fluence, can it not be done with track detectors?
I'm not sure. I mean, I haven't, but thank you very much for the idea. I can check if there is anything. So the thing is that, of course, maybe not lately.
Yeah. Yeah, I mean, there's quite a lot of experience in EURADOS with track detectors. We can have a discussion about that. There may be something that EURADOS could do and help.
Oh, that would be really, really great. Yeah. So all ideas are very welcome on that subject.
Yeah, thanks for the interesting presentation. Just to add some level of complexity. I mean, in principle, when you have boron, when boron captures a neutron, you get two densely ionizing fragments. How do you take that into account?
Yes, so we just assume that those alphas and lithiums, they are like locally deposited. So we know the energy what they deposit, and we just calculate the dose based on that energy deposited locally there. So is that what you mean? So we don't measure it. We don't, because we don't even know exactly where the boron is.
Yeah, I mean, my question was more going a little bit into the direction that basically it's particles that where people use external beam, they are using a weighting factor.
Yeah.
But
It's more radiobiological question.
Yeah,
Yes.
right.
Yeah. So that's actually something like there is. My feeling is that BBA is more used nowadays. Like, there is still BBA studies, radiobiology done, performed, and we are learning more. But still, I think focus is more in these new boron carriers. And then this is very good question to that, but I'm not right now that much experienced with this micro dosimetry. So basically, I think it's more about we probably are not measuring that so well. It's more about like defining the cell survival curves, like with different boron compounds, that type of thing, so that you learn like experimentally, so you don't need to measure it. You need to measure where the boron is, and you need to try to measure it at the cell level, like really where inside the cell or where inside the tissue, and then see the radiation response. So, yeah. Of course, then you need to calculate accurately the other dose components in your cell layer, and that's microdosimetry then. Yeah.
Further question? Yes.
Thank you for your presentation. So also related to the previous question a bit, so you have these very short-ranged particles. And I guess it's kind of important where the boron goes in the medium, whether it still stays between the cells, whether it enters the cells, or whether it actually enters into the cell nucleus. I would assume that it would make way much more damage if you have the secondaries being released within the cell nucleus than if it's outside of the cell. So I guess the weighting factors, the biological weighting factors would change accordingly. Now my question is, where is BPAF in this?
That's a very good question. So I guess we assume that BPAF is where BPA is, but that if fluorine 18 doesn't say that too much anymore, because it's still
BPA?
BPA. So BPA is, we know that it's inside this cell. I have to say that I don't remember exactly where, but it's inside the cell, that we know in cancer. But in normal tissues, we have lower RBE factors, so then it's different depending on the cells. But for example, like mucosal membrane, we see toxicity. So we know that it's also in the blood vessels, and in mucosal membranes there is like maybe lots of like small blood vessels, and we have boron there more.
I think I read somewhere that the old compound BSH had a very poor intracellular uptake. I don't know BSH, the old one.
Yes, I think that's true, yes. And the BSH is like, so Japanese have more experience on BSH, and they feel like it was nice addition to BPA because it diffuses in the, like kind of everywhere. So it maybe BPA requires more active cells. So if some of your cancer cells are in not so active cell cycle, when you give the irradiation, they may not have uptake in BPA. So then you should maybe have another carrier. But BSH alone, I guess it's not so effective. Yeah.
So if there's no further questions, I would like to thank you again, and also Nina and Mark.
Okay, thank you.
As the session is closed, we drink coffee. Yes.